Hello students, today we are going to deal with bronchiectasis, which comes under obstructive pulmonary diseases. So this X-ray shows some abnormalities. Can you notice the apex of the heart is towards the right? So implicating it is a case of dextrocardia. And look at the liver, it is situated on the left side. So this is a case of situs inversus. So by definition, bronchiectasis is a chronic necrotizing infection of the bronchi and bronchioles leading to abnormal and permanent dilatation of these airways. So if you recollect emphysema, which is associated again with abnormal, irreversible, permanent dilatation of the respiratory bronchiole, alveolar ducts and the alveolar sacs. Here it is in bronchiectasis, it is the bronchi and bronchioles which are involved in this abnormal permanent dilatation. Prevalence is 1 per 1,000 population. It has decreased in recent times due to effective antibiotics that are available. So basic pathology here is infection. So clinical features are very typical. In a long-standing case of bronchiectasis, the patient will have cough associated with fever, and this cough is productive, and he brings about lots of sputum which is foul smelling. So this is a very important clue to the diagnosis of bronchiectasis. So the person who is suffering from bronchiectasis will be coughing and bringing about voluminous sputum which may be around 0.5 liters per day, and which is very foul smelling. And dilatation, you should know that it is permanent. And sometimes reversible dilatation of the bronchi and bronchioles can occur in viral and bacterial pneumonias. Causes for bronchiectasis may be bronchial obstruction and hereditary or congenital conditions, and sometimes it may be associated with as a complication of necrotizing pneumonia. So this slide tells you some of the causes for obstruction like tumor, foreign body, or impacted mucus. So impacted mucus, if you recollect the bronchial asthma, so the secretions are so tenacious and they form a bronchial cast, and this is associated with obstruction of the bronchioles, and this can result in bronchiectasis if it is infected. And this chest X-ray shows another cause for obstruction. You can see that radio opaque shadow in the lower part of the right lobe, and this is a foreign body causing obstruction to the air passages. And here one more example, CT scan showing the obstruction of the right mainstem bronchus by a tumor which is growing from the lung into the lumen of this bronchus. So this is usually the appearance of carcinoid, and this carcinoid can cause obstruction, and long-standing obstruction results in bronchiectasis. And those persons who suffer from hypoxia due to some cause usually show as clubbing. And their sputum, if you allow it to stand for a longer time, it forms 3 layers, and you will call this as 3-layer sputum, which is very typically seen to be associated with bronchiectasis. The lowermost layer is the purulent neutrophils and other debris, and the middle layer is a clear fluid, and the topmost layer is a foamy layer. So this type of appearance of sputum is characteristically seen in the case of bronchiectasis. Coming to the congenital or hereditary conditions, congenital bronchiectasis may occur as a developmental anomaly, or the genetic abnormalities like cystic fibrosis, immune deficiency states, ciliary malformation may result in bronchiectasis. So the examples for this ciliary malformation which include this immotile cilia syndrome and Carter-Jenner syndrome. Sometimes necrotizing pneumonias can result in the formation of fibrosis or abscess formation, which heals by fibrosis, and this fibrosis pulls the bronchial tree, causing abnormal dilatation. Coming to the individual cases like ciliary dyskinesia, which includes immotile cilia syndrome and Carter-Jenner syndrome, here the ciliary abnormality If you recollect, the respiratory passages are lined by tall columnar type of pseudostratified ciliated epithelium. So this cilia beat in a rhythmic fashion and propelling the contents towards the oral cavity. So any abnormality in the ciliary beating is associated with the decreased mucociliary clearance, and this accumulated full secretions are a source of infection, and this may pose a threat mainly in the form of development of bronchiectasis. So this is the normal histological appearance of the pseudostratified columnar epithelium, which is ciliated. So this epithelium lines the respiratory passages, and this is electron microscopic appearance of the ciliary area of this epithelium. You can see some of the cilia are in longitudinal section and some are in cross section. There are some structures within the cilia. Let us see the structures in detail. Transverse section of the cilia, it has got some circular structures which are occurring in doublets. So there are 9 at the periphery and 1 pair at the center. Those at the periphery has some greenish extensions, outer and inner extensions. This is known as the Dynein arms. So Dynein arms, and the red ones extending towards the center, they are known as radial spokes. So any abnormality in Dynein arms or radial spokes may result in abnormal ciliary motility or non-motile cilia, and which is the basis for the development of bronchiectasis in these cases. So structure of cilia: 9 microtubule doublets at the periphery, 1 central pair of microtubules, and center and outer microtubules are connected by radial spikes, and Dynein arms, which are represented by green colored structures, they facilitate movement of the cilia. Again, the same thing, if you look at the transverse section of cilia in a normal person and in Carter-Jenner syndrome, you can notice the absence of the Dynein arms. So again, electron microscopy of the normal cilia and the ciliary dyskinesia or Carter-Jenner syndrome cilia, you can see the absence of Dynein arms. So the Dynein arms are represented by black arrows, and the outer Dynein arm, outer limb of the Dynein arm is absent in the case of ciliary dyskinesia. So the most common abnormalities in the case of immotile cilia syndrome or ciliary dyskinesia syndrome is the absence of either outer or inner Dynein arms and defects in radial spokes. And clinical features of ciliary dyskinesia. So they suffer from repeated bouts of otitis and sinusitis and recurrent attacks of chest infection, and they may have situs inversus in 50% of the cases. And if the person is male, probably they may be suffering from infertility too. So Carter-Jenner syndrome is one of the examples for immotile or the ciliary abnormalities. These components of this Carter-Jenner syndrome include bronchiectasis, situs inversus, sinusitis, infertility if the person is a male. Characterized by ultrastructural changes in the microtubules causing immotility of the cilia of respiratory epithelium and also sperms. That is the reason why they suffer from infertility. So these are the Carter-Jenner syndrome radiographs. You can appreciate the presence of the dextrocardia and the left-sided liver. So situs inverse cross section of the lung is showing some the radiopacities. Probably this is infection or the bronchiectasis. So it is a case of Carter-Jenner syndrome, situs inversus and bronchiectasis. And if you look at the ECG, probably it is reversal of ECG changes can be appreciated, especially in the chest leads. The chest leads will show progressive decrease in the amplitude of R waves from V1 to V6. Carter-Jenner syndrome and is associated with situs inversus. And what is the basis for this situs inversus? The cilia are present in the fallopian tube, respiratory passages, sinuses and CSF pathways, and also in the renal tubular system. So this cilia they are associated with propelling the contents towards towards one end, and they also work as mechanical sensors of something force, mechanical sensors of some force. So this is very important. When the embryo is developing, the ciliary motility, rhythmic movements of the cilia, is associated with rotation of different structures, which are this rotation is responsible for situation of the different organs in the body in a proper way. So any ciliary abnormality which impedes the motility may not facilitate this normal development and location of the structures, and because of this immotile cilia, the organs may be erratically located. So dysfunctional ciliary motility may result in major developmental anomalies, and cilia or hair-like structures, I told you already, and they beat in a coordinated fashion. They create a mechanical force. They can sense extracellular signaling molecules like sonic hedgehog and WNT pathways, and the SHH and WNT depend to some extent on the cilia with normal functional integrity. So whenever there is defective ciliary proteins, they have wide-ranging phenotypic effect. They are known as ciliopathies. So examples for these ciliopathies include retinal degeneration, the anosmia, and renal, hepatic, and pancreatic cysts, and postaxial polydactyly and situs inversus. So these are the examples for ciliopathies, and the chromosome and genes are associated with this. But remember, ciliopathies include this polycystic kidney disease, wherein the cilia sense the mechanical forces within the renal tubular lumen. If the cilia that are present in the renal tubules fails to detect the forces or flow within the renal tubular system, then it may result in what is known as cystic dilatation of the renal tubules, which are the basis for polycystic kidney disease in human beings. And coming to other disease which is associated with bronchiectasis is cystic fibrosis, otherwise known as mucoviscidosis. As the name itself indicates, the secretions or mucus secretions in these persons are viscid and very tenacious. So cystic fibrosis is a systemic disease. It is very rare in our country, but it is very common in Western countries with a prevalence of 1 in 2,500 live births. And usually pulmonary involvement dominates the clinical picture, and inheritance is in the form of autosomal recessive, and 95% of the deaths in cystic fibrosis patients are due to pulmonary complications, mainly infections and bronchiectasis. So in cystic fibrosis, the secretions will be tenacious and thick. They cause obstruction to the ducts and the lumen of tubular structures. Say for example, if it is causing obstruction, secretions which are very thick causing obstruction in the tracheobronchial tree, then the person lands in bronchiectasis. So if the secretions are very tenacious and causing obstruction in the gut, as soon as the baby is born, the baby suffers from meconium ileus. Sometimes this is a clue to the underlying pathology of cystic fibrosis. And cystic fibrosis, if it is causing obstruction to the pancreas, person may suffer from malabsorption, or in the course of time, because of recurrent attacks of the pancreatitis, the pancreas may be completely fibrosed. In the biliary passages, the person suffers from jaundice and cirrhosis. And in vas deferens and seminal vesicles, because of obstruction, the patient may have sterility. And in addition to that, another important thing is the sweat of cystic fibrosis patients will have higher concentration of sodium and chloride, and this is the test that is employed to detect the cystic fibrosis cases. So their sweat has got high concentration of sodium and chloride. And if you recollect the first slide, it shows a baby with some collection device. So that is a sweat collection device, and that sweat is tested for concentrations of sodium and chloride. And pathogenesis of cystic fibrosis, thick viscous mucus and impaired ciliary clearing, and results in repeated bouts of pulmonary infection and parenchymal damage and with the resultant fibrosis and pulling of the tracheobronchial tree because of this fibrosis and dilatation, which we will call it as bronchiectasis. And coming to the molecular basis for cystic fibrosis, the gene associated is CFTR, and it is located on chromosome number 7, and there are many mutations that can cause this cystic fibrosis, and till now there are 550 mutations that are detected, and with varying manifestations of cystic fibrosis. This slide shows the cystic fibrosis gene mutations with varying degrees of clinical manifestations. Some of the gene mutations may be just associated with poor sperm quality, and some may be associated with the absence of or obstruction to vas deferens, or in the severe form, the person may suffer from full-blown cystic fibrosis. Again, pathogenesis, reiterating, these patients will have thick tenacious sputum which fails to clear the tubules or the natural passages, thereby causing obstruction and accumulation, and this forms a source of infection, and bacteria grows and cause infection, and this inflammation results in abscess formation, tissue destruction, which is later on replaced by fibrous tissue. This fibrous tissue contracts or pulls the tracheobronchial tree, causing dilatation. Morphology, usually bronchiectasis affects the lower lobes, bilateral, and air passages in the lower lobes are vertical, and they are more susceptible for this bronchiectasis. And if bronchiectasis has got a basis for obstruction by a tumor or foreign body, then it may be localized to any of the single segment of the lung. Air passages are almost 4 times dilated than the normal. And there are some morphologically identifiable dilatations, which are usually radiological forms. We don't use it in pathology, and this may be described as cylindrical dilatation, fusiform dilatation, saccular dilatation, and varicose dilatations. Cut surface of the lung, multiple cystic spaces resembling honeycomb, so we call this as honeycomb appearance. And this is radiograph of showing some of the closer view of the dilated tracheobronchial tree, wherein you can see the cyst formations. So cystic variety of bronchiectasis. So this is cylindrical, uniformly dilated. You can call it as cylindrical variety of bronchiectasis. And again, this is the saccular dilatation or cystic dilatation that can be appreciated on the right base of the lung. The cross surface showing dilated bronchial tree, mainly affecting lower portions of the lobe, and if you appreciate, you can trace these dilatations till the pleura. So in a normal lung, it is not possible to trace the tracheobronchial tree to the pleura, and maximum you can go up to 2 centimeters from the pleura. So if you are going beyond that, it indicates it is abnormally dilated tracheobronchial tree, which is the basis for bronchiectasis. So again, you can see that dilated bronchioles, which are going almost up to the surface of the lung. And this is a lung cross section showing dilated bronchioles involving the entire lung. And this type of appearance is commonly seen in the case of cystic fibrosis patients, because it's a genetic abnormality affecting every portion of the lung, whereas in the case of typical otherwise acquired type of bronchiectasis, it is mainly confined to the basis of the lung. Again, because of recurrent infections, there may be adhesions and fibrosis. Adhesions, you can see that flimsy fibrous tissue located in the pleural surface of the 2 lobes, connecting them bridging them. So this is a fibrosis secondary to bronchiectasis. This is the microscopic appearance of lung involved in bronchiectasis. You see 2 bronchioles which are dilated, and lumen of these bronchioles are showing the inflammatory exudation. If you look at the epithelial lining of the bronchiole, there is discontinuity, so ulceration. And surrounding alveoli also show certain amount of exudation, so pneumonic changes are very common in these persons. And again, closer view to show the neutrophilic exudation in the lumen of the bronchial tree and ulceration that can be appreciated very well here. And the clinical course, they again, I want to reiterate that these fellows will have the severe cough, which is persistent, which is productive, and they bring about large quantities of foul-smelling sputum, and usually they will have recurrent attacks of infection and fever. And in the long-standing cases, the patient may suffer from dyspnea, orthopnea, cyanosis. So the complications of bronchiectasis includes the metastatic abscesses. So any focus of infection in the body may allow the entry of these organisms into the systemic circulation. You will call it as bacteremia, and they go and lodge in varieties of tissues in the body, thereby producing abscesses locally. And we call this type of spread of infection causing multiple abscesses in different sites as metastatic abscesses. And brain abscess is one of the complications of bronchiectasis. The person may land in pulmonary infections, which is recurrent, and because of recurrent pulmonary infection, fibrosis, the patient ultimately lands in pulmonary hypertension, and this pulmonary hypertension reflects mainly on the right side of the heart in the form of failure. So, right heart failure, secondary to lung pathology, you will call this as cor pulmonale. So, sometimes bronchiectatic patients may land in massive hemoptysis. So, to leave you, there is one question: which is the dreaded complication of any chronic inflammation? And you write your answers in the comment box, and in the course of time I will get back to you with right answer. Thank you.